Excellent. Today is Tuesday, August 26th. The time is now 9 a.m. The committee's purpose is to evaluate nurses requesting participation in the intervention program according to the board's guidelines and to make recommendations to the program manager regarding the terms and conditions of the intervention agreement. We're going to go ahead and do a quick roll call. I'll go ahead and start with Jana, and then as I call a member's name, if you can just state your committee role. Jana?
Here, I'm vice chair.
Laura?
Here, member. RM member.
James?
Here, position member.
And Osazua?
Remember to say full names when we're doing roll call to establish quorum.
Certainly. Osazua Omede?
Here. Member.
Okay. And then we'll just note for the record that committee member Kenya Smith is absent today. Quorum is established at 9:01. Okay. With that, I'm going to go ahead and open this to our meeting moderator to provide just general instructions on how we're going to run our public comment periods.
Good morning. This is the IEC moderator. I will be moderating the meeting. To facilitate public comment, we will be utilizing the WebEx question and answer feature. When the committee reaches a point in the agenda at which public comment is appropriate, I will provide instructions on how to use the WebEx question and answer feature, which is now known as Slido. We will also query the in-person location for any public comment. I will provide a brief reminder of this approach at the start of each public comment item. Finally, when the committee members or BRN staff are not speaking, I would like to remind them to mute their microphone. If I detect background noise during the meeting as a result of unmuted microphones, I will mute their microphones automatically.
Okay. Moving on to agenda item 3.0, public comment for items not on the agenda and items for future agenda items. Board moderator.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Meeting facilitator Clark, there are no public requests for comments on the WebEx or Slido. Do we have any in-person requests for comments there in the in-person location?
No. No.
Did I hear no?
Correct.
I heard none.
Okay, thank you. Would you like me to close this window?
Yes, please. All right, moving on to agenda 4.0, discussion and possible action approval of draft minutes from the prior meeting. The members were presented the draft meeting minutes from the May 28th meeting. Were there any questions or edits requested by the committee members? If none, can I request a motion for approval of the draft minutes?
I'll send a motion to approve it. I'll second the motion.
So the motion that on screen, you'll see the motion to accept includes. So if you could just read that, if that's how you want to do your motion. So where it says IEC meeting minutes from May 28th, 2025.
So the possible motion would be motion to accept IEC meeting minutes from May 28th, 2025, and allow board staff to make non-substantive changes to correct name misspellings or typos that may be discovered in the document.
Do you guys want to accept that? You could say so moved.
Okay, we have a motion from Jana. Do I have a second?
I second the motion.
Okay, we have a second from Laura. We'll go ahead and open this up to the public for any public comment. Board moderator.
We will be open for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Meeting facilitator Clark, there are no public requests for comments on the Slido request box. Do we have any in-person requests for comments in our in-person location?
We do not.
Thank you. Would you like me to close this window?
Yes, please.
Thank you.
Okay. Oh, still need to take a vote. Okay, if there's no other discussion on the minutes, we'll go ahead and do a roll call vote. I'll similarly just go through all the members' names, and if you can vote yes, no, or abstain. Jana Porter.
Yes.
Thank you. Jana Porter, yes. Laura Thomas.
Yes.
Laura Thomas, yes. James Lozano.
Yes.
Thank you. James Lozano, yes. Osozua Omede.
Yes.
Thank you. And I got a yes. Motion carries. We'll go ahead and go on to agenda item 5.0. This is an information only item on intervention program updates. General information, management continues to work with Premier Health, attending all IEC meetings, providing education to committee members, and identifying possible gaps in regulation for the intervention program. In regards to committee vacancies and recruitment, the board continues to recruit IEC members with knowledge and experience in the treatment of substance use disorder and mental illness. To apply for IEC positions, interested parties can find the application on our website at rn.ca.gov and /intervention. In terms of IEC outreach, board staff in collaboration with Premier staff is in the process of updating our outreach brochures and posters. The board emailed 1,312 outreach materials to individual nurses this calendar year, and that information is provided. As far as the brochures, I believe there's a link on the next agenda item that the members can review as well. Is there any discussion or questions from the committee? Okay, hearing none. Board moderator, can we open the public comment period?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I would like to give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Meeting facilitator Clark, there are no public requests for comments on the Slido WebEx. Do we have any requests for comments there in our in-person location?
We do not.
Thank you. Would you like me to close this window?
Yes, please. Thank you.
Thank you.
Okay. Moving on to agenda item 6.0, information only item regarding requirements for participation and completion of the intervention program, including requirements of working in positions involving direct or indirect patient care and or furnishing or administering narcotics to patients. I'm going to go ahead and invite Loretta Melby, our executive officer, to provide a review on this as well as on individual program participant requirements. All yours, Lori.
Thank you, Lorraine. I appreciate that. So my name is Loretta Melby, or Lori. I'm the board's executive officer. I'm sure you guys are very much aware. The last few years, we've received a lot of, excuse me, a lot of public comment regarding the management of our intervention program and the participants. We were attempting to do a group education. However, with quorum and everything with that, we were not able to get that planned. So going forward, I will be opening up in open session all of the IECs and providing education. This is not just a one-way kind of lecture. So I do want to make sure that you guys are interactive. I would love to have any questions to be presented. If Premier staff is in attendance, I would love them to be able to provide questions and input as well. So we will work to facilitate that. One of the things that I noticed today, just kind of a little bit off topic with the IECs, is coming in and such. I did notice that we're not recording the open session and we hadn't been posting that to our website. That will change. We did make an agreement with Department of Consumer Affairs that we would post and record all of our open session meetings. So going forward, we will record this and you will find this on our website to be able to reflect back. Additionally, this does get posted typically on YouTube, where everybody else is able to access it as well. So this training session, just for you guys to be aware, can be followed up, relooked at, checked in the future to see if there's any updates or any questions or comments or anything around that. And this is also available for the public to view. So with that, with a lot of the changes and everything that's been going on, our board August a year ago asked me to start doing training related to the board's motion. In the materials that were provided to you today, there is a copy of the board's motion from August. And in that board motion, it talks about the direct patient care aspects. So I want to kind of go into that first, and then we'll expand from there as needed. So the motion that was put forward by our board in August said to suspend the imposition of the requirement that participants work in direct patient care unless there is an additional evidence of patient safety issues. Suspend the imposition of the requirement that participants work passing narcotics unless there is additional evidence of patient safety issues. If an IEC recommendation extends the length of the program beyond 3 years, the executive officer must review and examine the evidence. In any cases in which either and or both of these requirements were the only requirement preventing a participation from successfully completion the program, and where those requirements are removed pursuant to this motion, direct board executive management to work with the intervention program manager to have such cases presented to an intervention evaluation committee as soon as practicable, for consideration of the program completion, and direct board executive management to provide an update to the IEC at the last annual October, November, or December meetings regarding cases in which these requirements were removed or imposed pursuant to this motion. We have continued to provide updates to our board every probably about 8 times a year, because we started up the intervention evaluation committee. The intervention program committee meetings as well. And so that is taking place the month before our board meetings. You guys are always welcome to attend as public and watch that. And if you needed to do a public comment or something at that point, you could as well. Just wanted to make sure that that's available and open to you. We do post it to our website. Since this motion was put into play, I have received 56 reviews. What that means is that there are 56 times that IECs have continued to ask for direct patient care for completion, continue to ask for passing of narcotics for completion, and continue and have extended people beyond 5 years. I will add that additionally, I have reviewed any of the terminations that have come forward as well to ensure that there is evidence to support those. My role is not to overturn the committee recommendation. It is to ensure that the recommendation is supported in evidence and within alignment with our board's motion. So with that, 19 of those IEC recommendations I've upheld. I've said, yes, there's evidence to support it, and it has moved forward. 31 have been kicked back to the IEC for reconsideration because either there wasn't evidence of additional patient safety issues that warrant the requirement of direct patient care or narcotic passing, or there was questions on how this recommendation came to be. So with that, you have had our board staff present, taking notes, kind of helping you with those motions. But I really want to have kind of a conversation around this if you guys have questions on the change, on whether or not you have an understanding of the uniform standards as it pertains to this. I know that Uniform Standard 12 has really been looked at where the IEC must determine that they're safe to return to practice. One of the big issues that our board has kind of talked about and raised is they would be safe to practice if they weren't having a mental health issue or a substance use issue. Once the mental health issue and the substance use issue has been addressed and they're in appropriate recovery from that, we don't have to ensure that they know how to be an RN or that they work necessarily as an RN in the same capacity that they were in. Our license is a general license. It allows you to be an RN in any role. I'm an RN. I'm the executive officer of the board. I will never pass narcotics. I will never do patient care. I did that for many, many years, and I don't foresee me doing that ever again. Can it happen in the future? Yes, I could 10 years from now decide to go back into patient care if I, for some reason, was led to do that. If that happens, and if I were a participant of this program and I succumb to a substance use disorder again, or my mental health issues flare up again, I have the opportunity after successful completion of the intervention program to rejoin the intervention program and seek help again. We are not going to ensure that they never relapse or that they never have a mental health issue again. That's not something that we can do. So what we have to do is review the information that's presented in front of us, listen to their case managers that they're through our vendor, which currently is Premier, previously it was Maximus, get their feedback because they are interacting with them the majority of the time, and listen to, you know, our staff in conversation and review their documents. If they're showing that they're working their program, if they're showing that they've got the support and they can continue to be, as much as we can determine, sober or in control of their mental health, we have the ability to review them for completion. That is, as long as, of course, we're following the uniform standard requirements and those are met. So one of the comments that was brought up to me is, do they have to work at all? That would be awesome. We would love them to work in some form as an RN. In the uniform standards, it talks about being released to full time, and we would love to release them to full time. And in doing so, they have to work 6 months or 2 worksite monitor reviews in a part-time position before they can go to a full-time position. Again, that is in any role as an RN. There is nothing that says they have to do patient care. There is nothing that says that they have to do to pass narcotics. So I wanted to make sure that that was clear. Now, if they're working as an RN and you guys have cleared them to go to, you know, RN without direct patient care, fantastic. You guys clear them to do RN with patient care, great. It shows that they're doing progress. They're making progress in their sobriety or mental health. And then you progress them to being able to access narcotics. Well, at that point, you have determined that they are safe to go back to work, or you would not have made those motions, right? Now, while they're in the program, they do have extra support, right? You're making sure that they're doing their meetings and they're turning in the reports and they're checking in, and we're doing the drug screens, and that is fantastic. But with the clinical evaluators review saying that they're safe to return to practice, with your guys's gradually progressing them through the program to go from no patient care to narcotic access, you guys have also concurred that they are safe to return to practice. And what we're doing at this point is monitoring them to ensure that they continue to do well in their program. Evidence says that sobriety maintained for 8 years can pretty much be counted on for that to continue. We don't have an 8-year program. So we have a 3 to 5 year program. And in that 3 to 5 years, hopefully there is evidence enough to support that. Now, if they are in a non-patient care RN role or a patient care RN role, and we do see that there is some patient care safety issues that arise, that is when we have the opportunity to say, you must work in patient care. You must have narcotic passing. That is when we evaluate it, we see the additional patient safety concerns that have popped up that then justify you guys making that recommendation. So those are some of the concepts and stuff that we wanted to talk about. With that board motion as well, they did talk about getting in front of an IEC as soon as practicable, so that is also why you may see members that are not yours. And so at this, I will be quiet and I'll allow you guys to ask questions. I am having a hard time hearing you guys, so I will make sure my volume is elevated.
Lori. We lost
There's
you
a
when-
bad kind of feedback. I'm not able to hear you guys clearly.
Hold on.
I'm muted again, so who else has our sound on?
So we couldn't hear the last few minutes. We had lost volume here in the conference room.
So Lori, I think they said that the audio cut off towards the end, so they didn't hear the last portion of your presentation.
Yes.
We happen to know what the last part was that was heard? I'm not able to hear anything from the room.
Yeah, the room is on mute. If someone would be able to unmute their microphone at the in-person location.
Okay, that fixed it. Lori, the part that they didn't hear is when you were saying, so you can, and it's when you were talking about when it may be appropriate, I think, is where you were getting at, when it may be appropriate to extend past the 3 years, or where it may be appropriate to work with narcotics or indirect patient care.
There are several factors that can be used to determine whether you extend past 3 years. The program is 3 to 5 years. And so you guys can, as long as you support that in evidence, that's fantastic. That's what I need to see is like, what is leading you guys to recommend an additional time in the program? Are they showing that, a common thing that I see in our review is they've had a great time through the program, but here in the last few months, they missed a call in. They didn't turn in something that they needed. So it's showing that kind of they've got it's like senioritis. They're getting close, but now they're starting to not follow the program as much. And so at that point, I see you guys routinely, and I say you guys as the greater IECs, there's 9 IECs, correct? And so what I see at that point is I see maybe you guys extend 3 months and say, give them another chance to get back to 100%. And I want to see this. If you're waiting for, there was some concern on maybe the last worksite monitor check-in. It wasn't a violation, but they said, you know, we had some concerns with that. You want to then reevaluate them in 3 months and see if you can get another worksite monitor report back that then says, nope, that was a fluke, everything is good. So those are some of the reasons why I can see going past three years. The extension in the program seems to be kind of an easier thing to justify, right? Where we look at the requirement for passing narcotics and working in direct patient care, the board's motion says that there has to be an additional patient safety risk. That what in review, what I've seen commonly is that they diverted prior to coming into the program. And so that's why you guys want them to work in patient care or pass narcotics. And that is not something our board supports. If the diverting in patient care prior to coming into our program is 3 to 5 years ago. And when they're diverting in patient care, they're doing that because of their substance use disorder. They're doing that because of their mental health issue. if you guys are able to determine that they are following the program and that they are working their steps, then that substance use disorder and that mental health issue is under control. And if they choose that they do not want to work in patient care during this program, they're continue to work their program. That means, you know, what the board is able to take a look at that for is what they say, well, you wouldn't tell an alcoholic to go into a bar, right? You wouldn't tell an alcoholic to actually become a bartender, right? So if in their recovery, the participant says, I don't want to pass narcotics, that's not something that I feel comfortable doing, our board is okay with that. That is their prerogative to never work in a direct patient care role again. That is their prerogative to never have access to narcotics ever again, because they are working their program that is individual to them that says, I will not do that. Now, what the pushback that we receive on that commonly is, what happens if they get a job passing narcotics and working in direct care in the future? Well, the hope is that at that point, through the provider's evaluation that says they're safe to return, through their working their systems and having different support groups and support people in their lives, that if they do choose to make that choice in the future, that they will have the tools to work through that, right? There's inner circle activities, there's outer circle activities, or all those kind of activities that come into when we're dealing with mental health and substance use disorder. Of course, we want them to make the right choices. We can't determine what those choices are going to be in the future. So what we can do, which is what we currently do to every RN in our state, is if you have a problem, you can come back into our program if you successfully have completed in the past. And so recovery is always an option. Recovery is always there, depending on their ability to work their system, which is what we put in place to do that. Did that answer your question?
Yeah, I didn't know if you heard that, Lori. They said, yeah, I guess.
Did not. Okay, there is still an echo there. Just want to let you guys know that that is still happening. Do you guys have any questions for me? Any comments? Any things that have come up through this that you guys would like clarification?
Jean has a question, but if the committee can unmute the microphone so we can hear Jean's question.
We're going to use yours. There you go.
It's not a question, it's just a comment. You know, we are here as an IEC committee for a purpose. And some of us do have experience in recovery. And we are evaluating, you know, it's not always black and white area. There's a lot of gray areas. And at the end of the day, we're determining whether or not they're safe to go back to patient care. And if someone is diverting in a situation, they go back without ever practicing dispensing drugs with supervision to see if that's something they are able to do, then we are determining that they're safe without ever evaluating that situation. And if something were to happen to a patient, ultimately that falls back on us for making that decision without having the proper information that we need in order to determine whether or not that person's going to be safe. Now, there are a lot of nurses that say, I don't ever want to pass narcotics ever again, and that's great. But how do we know that that's going to be the situation once we determine that they're safe? To me, something like that, passing narcotics, is not asking them to bartend if they're an alcoholic. it's part of the job requirements for nursing in a lot of jobs. It's just something that it's just hard for me to understand that we can just skirt past without determining just whether or not they can be capable of being an RN, if that makes sense.
So being capable of being an RN is broad. You are saying that they're safe to practice. Practicing RN is vast. You're not saying they're safe to do patient care. That's not been the ask. Many people work as an RN and are not doing direct patient care. There are multiple jobs out there that do that. Even in doing direct patient care, there are many jobs out there that do not require narcotic passing, right? I can be a circulator in an RN, a circulator in an OR, and I will never pass a narcotic, right? That's the anesthesiologist's job or the CRNA's job that's in that room. I am doing something completely different, right? I can work as a case manager and I will never pass a narcotic. I can be in a dialysis clinic. I'm not going to pass a narcotic. I can be an educator. I can be an administrator, and I'm not going to pass a narcotic. So our license is broad. In our license, they've been determined safe by receiving licensure in the past. They know how to pass medications. They know how to access medications. They know how to check medications. What we're worried about is, are they able to access those medications and maintain their sobriety? Are they able to access those medications and not have their mental health issue arise again in a way that is not manageable, that is a risk to the public? Passing medications is a basic licensure safety thing that they've already showed us that they can do. What they didn't maintain is their sobriety or their mental health. Their sobriety is what made them not be able to pass narcotics in a safe manner, because it affected their sobriety.
Can I ask a point of clarification?
Yes.
I believe you did address this. If you could just recap the goal of this conversation, whether to not mandate direct patient care, to return a nurse to full licensure without restrictions and basically graduate the program. Is that going forward because there's been like a public outcry? Is it to kind of just pass people along so that we can free up space? Or is it more the public outcry? For example, there are multiple situations where someone is in case management, they have a full position, they love it, and they want to just be done with the program. That's typically the issue, is they say, well, how can I get a job in patient access if I have this full-time job? That seems to be the biggest issue I see. Is that where this is coming from? Just so I understand.
What's coming from is a couple years ago, we started to receive a lot of outcry saying they are required to pass meds, pass narcotics, and receive patient care. That is when our board started taking a look at this and saying, what is actually going on, right? This motion that I'm talking about was presented a year ago. This motion has been in effect for one entire year, and the majority of our IECs, when they're going through this, have been able to move through, successfully complete, do that entire process for the last year. There has only been, let me just pull my statistics back up again. There has only been 56 cases brought in front of me in the past year for a re-review. And of those 56 cases, 19, I have been able to show that it's been supported in evidence. Only 31 has been kicked back to the IEC to say, hey, take a look at this again. I don't think you guys are necessarily following what our board has actually stated. So not pushing them through, absolutely not. That's not our role. Our role is to determine that they are safe to go back and practice as an RN, knowing that the role of an RN is vast, right? So what are our minimum standards that we are willing to accept? The other comment that was said is, are we trying to clear up space? No, we have more space than we need. We would love to have more participants. We're seeing a declining enrollment rate. We're seeing a declining participation rate. So we are not trying to clear up any space at all. That's not the intent at all. The intent is to, as we started to do the review of our IEC, probably 2 years ago, Shannon, you and started to kind of look at the IEC and see where we were in compliance, not in compliance, and we were working with Maximus at that point. What my understanding is that occurred is messaging got out through Maximus that was incorrect, saying that people had to pass narcotics, people had to do direct patient care in order to pass. We do not have a law that supports that. What our law says is everybody would be determined on an individual basis. And what, with the complaints that rise with that, our board says we need proof, we need evidence as to why this is being asked. Because if this is just based on a directive that was not accurate, that needs to be addressed. If this is something that is being applied standard that says if you diverted, you will go into patient care, you will go into narcotic access as a requirement for completion, that can't be done either because we don't have a regulatory authority for that. It has to be determined on an individual basis. And so with that, our board got involved and started really looking at things because something occurred about 2 years ago that caused this change in the way that our program has routinely been run. There was never a requirement in the past that said you had to do direct patient care and you had to do narcotic passing. That just occurred 2 years ago to an extent that it caused a severe public outcry of saying this is not how we were told the program is going to be. This is not how the program is ran for the last 40 years. Why is this all of a sudden popping up? So that happened about 2 years ago. We made this motion, our board, sorry, I'm just the messenger. Our board made that motion about a year ago.
I have another question. How many stats? Stats are kept on those who fail the program and return, right? Or is there ever data? Like I love numbers and I love to try to connect.
Yeah.
The evidence shows. What stats do you have on those? Well, the very specific issue of nurses who are returned to the workforce, who graduate from the program and return, how many of those diverted and were not in direct patient care when they left? Those are very specific. That's very specific information. You may not have that, but I'm just
we don't. We don't have that.
Okay.
Yes, so we don't have that data. What we're involved in a program with National Council of State Boards of Nursing, where our program is in alignment with successful completions.
Okay.
And so we are following the guidelines of what the National Council recommends based on evidence and studies out there that support that. Our program aligns with that. Our program is actually much more stringent in some ways, especially with the drug testing and stuff, than what is recommended. Many of our participants have more support group meetings than what is recommended. Every board of nursing in our nation has different standards for their alternative to discipline program. Some of them require them not to work the entirety of the program, and only upon successful completion can they go back to work. And that is completely opposite of what we do, right? We require them to do some kind of work prior to going in. So there is nothing across the board that says nurses or any professional must work in the role that they were in prior to having a substance use disorder or a mental health issue that arose. that's simply, there's just no evidence there to support that. And that is across the board, nationwide, in many boards of nursing, et cetera. So specifically, even just showing that there are programs that are 2 years in length, 3 years in length out there where they require them to not work at all. And then work only after completion. So what we have data is we have our successful completion. We have a high number of successful completion. When you successful complete, you are able to return to our program in the future if you ever need it again. It's when you are unable to successfully complete, you are then barred from returning to our program in the future, right? It limits them from the assistance that we can offer them.
Thank you for clarifying.
Yeah, you're welcome. And I know that this is really messing with everybody's head. I get that. It's a completely different direction than what you guys serving in your current IEC roles are probably familiar with. Understanding that this change only happened probably 2 years ago. You know, prior to that, there were successful completions without direct patient care. There were successful completions without narcotic passing. And we did not have a spike in recidivism. We did not have increased outcry in public harm saying that this is what's happening. It was just about 2 years ago where this came kind of out from reported, where I have no evidence of this, but it's reported that the prior vendor notified participants that a change was in place, saying that all people were in the program were going to have to do patient care and pass narcotics in order to complete. Again, that was a huge change, and that was not something that our board supported. And then maybe one of the things that you guys missed, which I'm not sure the part where the audio cut off, but as you guys are aware, there's a provider that is being used, and that provider says they are safe to return to direct patient care. That's one piece of evidence that you guys are able to take into consideration. And then as you guys are evaluating them through the program, you're able to say, I think you're working the program enough to go to start working as an RN again. Okay, I believe you're working the program enough that you can go to direct patient care if you choose to. And even at that point, I think you're working the program enough and you're in compliance with everything that you could access narcotics if you chose to. As you are progressing them through that steps and you are getting to the point where we're decreasing the drug testing and you're showing that they're in compliance and you're progressing them to have access again, you are determining in those steps that they are safe to return to practice as a nurse. What you're doing though is in a very controlled environment, right? Where they're required to do check-ins, they're required to drug test, have a worksite monitor. So ultimately, as you guys progress them through that, there is a hope that the person has more abilities out there because they have been released to patient care with the ability to pass narcotics, that if they do choose to get a job in that, they can. But that is not a requirement to pass unless there is a patient safety issue that's been brought in front of you. And you say, you know what, I see this patient safety issue. We need to address this. If there's no patient safety issue brought in front of you, we cannot force them to work in a certain capacity.
I have a question.
Yes.
You keep saying unless there's a patient safety issue. To me, a
Correct.
patient safety issue would be they used to divert, they had a drug issue, and now they're going to go back to patient care without having shown that they can do those things prior. To me, that's a patient safety issue. So do you have an exact definition of patient safety issue that we can go by?
Yeah, so you look at root cause, right? What is the root cause of that? The root cause of that is the addiction. The root cause of that is the substance use disorder. So if you're able to address the substance use disorder, then that issue no longer lives there.
That's not true though. With recovery, statistics show that this is a lifetime disease.
It is, yes, but you've given them the tools to manage that lifetime disease. And so if your argument is that this is a lifetime disease, then we could never release them to patient care. We could never release them from a monitoring program. So we have to find enough evidence that says you feel comfortable to release them.
That's fine. She's telling you what your argument is. I don't. Let's move on.
I just implore you, when you're referring to evidence, if we could maybe even create an ad hoc committee that could start taking statistics so that we can see the statistics to help us feel more comfortable in making our decisions moving forward.
We have a program that we're involved in. They're in the final 2 years of that program, collecting evidence of people that have completed and whether or not they'll have recidivism. So they've completed the first 3 years of that 5-year study. We will have that study completed in 2 years with evidence that shows whether or not people that have completed in 3 years working the program as designed, which does not require patient care and narcotic passing, is able to allow them to successfully return to work and not have recidivism. So there is a nationwide study that is going on right now with the National Council of State Boards of Nursing that are doing just what you're asking. And we are involved in that as one of the largest boards.
Great. That's great.
Thank you, Loretta. Do we have any other comments or discussion from the committee? If none, let's go ahead and open the floor to any comments from the public. Committee moderator.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Meeting facilitator Clark, there are no public requests for comments on the WebEx Slido. We have no in-person representation there in our location for the IEC. Would you like me to close this window?
Yes, please. Thank you.
Thank you.
Okay, real quick, Lorraine, just to wrap up. If you guys have individual questions that you'd like to meet with me and have conversation about, you feel free to reach out. It's loretta.melby@dca.ca.gov, and I'll spell that LORETTA.MELBY@dca.ca.gov. It is not a violation of Bagley-Keene for you guys to reach out and speak with me. So you guys can reach out and speak with me. We can set up a Teams meeting. We can have any kind of conversation that you would like to do following up on this. And understand that in the IEC recommendations that have been put forward to me that do include direct patient care, that do include requiring narcotics, that do include extending the program, 19 of them have been supported. There has been 31 kicked back, but 19 have been supported. So if the evidence is there to support this, you guys are able to move forward with those recommendations. It is not a complete abolishment that doesn't allow you guys to do that. What you guys have to do is support it in evidence. There has to be a plan in place for that. And it should not just pop up in their last 3 to 6 months saying, but now you have to do this. That should be a plan in place that this goes forward and they know that the goalpost is not being moved without any kind of evidence to support that. So appreciate your time today. I will be going to all of the other IECs and I will be back in IEC 3, probably your next meeting. So if something happens between then and now that comes up and you want to reach out, I will be doing another kind of ongoing educations for probably the next year. And so you guys will see me in the future. Thank you.
Thank you. With that, we'll go ahead and move on to agenda 7.0, discussion and possible action reviewing the IEC member guide and intervention program regulations as provided in California Code of Regulations Title 16, sections 1446 to 1449, and provide recommendations to the board. So board staff, we always ask for our committee members on an ongoing basis to review the IEC guide and to feel free to offer feedback to staff regarding any areas where the information can be developed further. The board is responsible for onboarding and training all the IECs and ensure members are that you're successful in your role. So again, we welcome any feedback, questions you may have on the guide. We also are always seeking feedback in regards to the regulations themselves to ensure that we are fulfilling our legislative mandate. With that, is there any discussion or feedback from the committee? Hearing none, board moderator, can we open it up to the public?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I would like to give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Meeting facilitator Clark, there are no public requests for comments on the WebEx. We have no in-person representation in the IEC location. Would you like me to close this window?
Yes, please. Thank you.
Thank you.
All right. Moving on to agenda item 8.0, discussion and possible action to adopt the proposed 2026 meeting schedule. Each committee meeting must have a quorum of members to comply with the requirements of the Back-Licking Open Meeting Act and to review registered nurses in the intervention program. Historically, as you all know, our IEC meetings have been held quarterly. However, to better meet program needs, staff is proposing increasing the number to 6 meetings in 2026. The proposed schedule below that has been provided to our committee members considers upcoming board and committee meetings as well as state holidays. The committee is asked to review and adopt a 2026 IEC meeting schedule. And again, staff have already prepared and proposed a schedule for 2026 IEC meetings. For this meeting, we are proposing dates of January 14th, March 11th, May
Is it-
20th, July
Lorraine, is
20th.
it possible to share that on the screen?
Yeah, I couldn't find it because I put it in my calendar, but
Okay, just hang on just one moment and we'll have Lorraine share that on the screen so you see
Sure.
summary.
Just a moment.
There you go.
Is
So if you
it-
can just enlarge that slightly, there's the 6 proposed dates for next year. All here at the dental board, all fall on a Wednesday.
oh, those are my. Or is this? Is there? a beginning of There it is right there. Let me see. Because I had 12 dates I put in my calendar for, let's see here, 2026. Just
Thank you, Lorraine.
Sure.
The committee a moment to review these dates.
yeah, those are not the dates I had. There was another list of dates given in the email sent out. So I'm a little, and I put them all on my phone and now they're different. So
I pulled my agenda item summary up from the items that were sent out in your meeting materials, and these are the dates that I have.
I don't know what I was looking
Yeah,
at.
I'm not sure what you're
Okay.
referring to, but
All righty.
these are the 6 dates, so it's every other month starting in January. Does any of the committee members have any concern about any of these meeting dates? Again, we just need quorum in order, but we want to make sure that we have the majority here because we have run into 3 quorum issues already this year and have canceled 3 committee meetings.
I will not be in town July 22nd. After January 14th. January 15th.
But there's no major concern. I mean, if there's one committee member that can't make it. But overall, I'll be back. Do these dates look okay to everybody? Any discussion on these dates at all?
I don't see a problem. I don't know about anyone else.
Would anybody like to motion to approve these dates for 2026?
You guys good?
I'm gonna vote no, so I'm not gonna make a motion. Go ahead.
So I heard a no, I don't think I heard a motion.
Hang on, you haven't got a motion yet. Hold on, they're still talking.
Do you want to make a motion or change something?
I don't want to keep what it is.
I see. Yeah.
Okay, any further discussion or emotion? Is no one wanting to motion to move forward with these dates for next year?
I'm just curious why the change from every 3 months to every other month?
So I'll explain. So from a previous board meeting last year, if any of you have watched and I believe we've reported on it, the board approved the EIIC to go ahead and for intervention to go ahead and open up to 4 more IECs. So we have the option of opening additional IECs, which would be recruitment of an additional up to 20 more IEC members, orienting them, and then trying to move around other members so we don't have them all beginning in one meeting and one committee together as a new committee, and trying to filter in some seasoned committee members. This was another alternative to that. And so we thought we would try the 6 meetings per year per IEC, see how that goes. We will reassess, of course, into the year and see how this is moving along.
Doesn't the job description for finance say the quarterly?
There is nothing in statute or regulations that states the number of meetings for IEC to meet, that we would create an IEC and the makeup of the IEC and criteria for each of the members.
I can't guarantee I'll get all those dates off.
And that's fine. The other thing we've run into is when we have an IEC that cancels because of quorum issues, we then have a large number of participants that will need to be found another home and cannot wait another 3 months possibly to go to their IEC again. So we're trying to eliminate that large period of time to struggle getting them in to see someone because either they had maybe for positives, maybe for returning to work. So there's money involved there in livelihood, or, there's been some sort of non-compliance.
Well, I make a motion to approve the schedule.
Okay.
And we'll just see how it goes.
Okay. Is there a second?
Second.
Okay.
All right, I have a motion from Laura Thomas, and I believe I heard a second from
Dr. Omebi.
Dr. Omebi, okay.
Yeah.
We'll go ahead and open this up to for public comment. Board moderator.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Meeting facilitator Clark, there are no public requests for comments on the WebEx. We have no in-person representation in the IEC meeting in Orange. Would you like me to close this comment? Would you like me to close this window?
Yes, thank you.
Thank you.
All right, if there's no further discussion, we'll go ahead and do a roll call vote on item 8.0. I'll go ahead and start with Laura Thomas.
Yes.
Oh, I guess I went out of order a little bit. Jonna Porter,
Yes.
James Lozana,
No.
thank you. Osazua Omede.
Yes.
Okay. With a vote of three yeses and 1 no, the motion carries. And we'll go ahead.
I thought we were doing.
I'm sorry, I
Sorry.
missed that.
We were voting. I thought that you said that we were doing a roll call.
We were voting.
We were
I-
voting for
I was
for the motion to adopt the 2026 IC meeting schedule as proposed.
I don't think it changes anything, but my vote is no.
Okay. Should I go through all the votes again, or?
I don't think so.
No.
Okay,
You have
So with-
two yeses.
Yeah. 2 no.
okay, with 2 yeses and 2 nos, the motion does not carry. Do we want to have further discussion on this topic?
Well, I mean, I think the issue is, well, yeah, I'm just curious if increasing the number that established IEC members are supposed to attend, if the likelihood of all of us being able to attend all those meetings is not high, And would that create problems with a quorum if you have a pool of other IEC members? Because I've seen how you've restructured it.
We don't have, I'll tell you, very seldomly do we ever have all 5 members show up to the meeting.
True.
And
True.
that happens now. So even if we added a couple more, we're probably going to have the same issue. The problem that we're running into is when that 3rd member can't make it. So then you have 3 that aren't present, then we don't have quorum. So we're just increasing our odds of being able to have additional meetings.
Yeah.
With that said, is there still room to get another number for this IFC, or is it full?
This committee is full. We have 5 members appointed to this committee.
This IEC is full, so Kenya, who is our chair, is absent today. So there's 5 members. Yeah, she is.
So she is.
She's your chair, member, yeah.
Yeah.
Yeah, so,
Will be
she
coming
is,
back.
yeah, she is your RN member, as the 3 of you are the RN members. Yeah. And so you have all 5 members that are voting members. You all have your own role within this committee as far as your.
Yeah, that's why I voted yes, because they're, like, I have opted out sometimes.
Maybe we could work out something internally between ourselves. Rotating.
Well, you can't talk about committee business outside of the committee.
Yeah, right. Yeah. I vote to go ahead and just put the dates on, and then, because it sounds like it'll be very similar to how it is now, but it does increase the likelihood that participants needing to be seen can be seen,
It will
and I
also
understand
increase
that.
the fact of having your own, so everyone assigned to you as an IEC, instead of them going to another IEC for something, the likely chance of them being able to go and keep going to the same IEC
Mhm.
is increased as well.
Yeah.
So you don't have an IEC seeing, 4 or 5 participants that maybe they're not familiar with, that they can actually having it every other month as opposed to every 3 months.
Yeah,
See, my concern is we make a motion to do these, but I can't make certain dates because my boss doesn't give them to me. In the past, when I've missed a few dates, I've gotten a letter stating, asking me to resign because I wasn't attending enough. I don't want that to happen again because I obviously want to be here, but I have, 2 jobs. I can't.
Right.
When I was hired on, I was told it was this amount of per year, and now it's increasing. So I don't want to be held accountable to that and look like I'm a poor member. If that
Yeah,
makes sense.
and that'll be taken into consideration too. I understand what you're saying, John.
although at least it's not 2 days so.
No, and that's
It's a little bit
also,
less,
that's
but
the
it
other
is
thing
only
that
a
is
single day,
eliminating.
which is very
That's right.
nice.
It will be
Yeah.
eliminating any 2-day meetings.
Yeah, which is good,
Mhm.
which is good. Yeah, that's more workable for me.
Okay, if there's no other motion to move forward with this, it is just, we can table it and defer it to your next IEC meeting. We will,
Possibility to have the days like we were doing before, but then voluntarily sign up for additional dates, or.
yeah, I
don't know
just want
because
to,
the public. Never.
to coordinate an
Yeah, so my
IEC
own
meeting
question.
and attendance is a very large undertaking.
Yeah, I just
Yeah.
don't get what
So when we
Yeah.
pre-plan, it's coordinated, we can reserve rooms, and all of that up front. Trying to, especially with the 3 cancellations we've had this year, trying to scatter and coordinate and emails and meeting space and all of that has been more of an undertaking then.
Yeah.
Why will they not allow us to sign in from home?
It's basically,
Brief the-
it's the law. It's part of the law that requires you to be here in person.
Yeah. But not the participants.
No, or board staff.
Bagley King requires at least a majority of the committee, which in this case would be 3 members and 1 staff person, to be at the in-person location.
Majority meaning? No, we have to have quorum.
Oh,
We have to have at least 3 members.
Gotcha.
And, you know, if someone does come in remotely, that would have to be approved because we would have to make sure that it meets the criteria for Bagley King.
Yeah, like when I had my surgery,
Yes,
it's still able to make it from home.
Yes.
You guys had to put a motion, which I
Right.
appreciated.
okay. So how are we with this agenda item? Where are we sitting with this?
We're just moving on. We have
Okay,
motions
moving
made.
on. Okay, so go to the next agenda item, please.
Okay, we'll go ahead and move on to agenda 9.0, which is our closed session. The committee will convene now in closed session. It is 10:12 to discuss and vote on matters related to the intervention program applicants and participants. Immediately following closed session, the committee will reconvene in open session for the purpose of adjourning the meeting.
Okay, it is 4:25. We are reconvening into open session. We'll do a quick roll call to establish quorum. John Porter. Here. Laura Thomas.
Here.
Dr. Lozano.
Here.
And Dr. Omedi.
Present.
Present. Okay, everybody is present. We are closing open session at 4:25. Thank you.